Welcome to good evening. Welcome to the educational webinar series of Turkish Society of Pediatric Radiology. Today we have a very special guest, and I have a great pleasure to introduce Dr. Andrew TROUT. He is currently the Director of Clinical Research and Nuclear Medicine at the Department of Radiology and Medical Imaging at Cincinnati Children's Hospital in the United States. He is board certified in diagnostic radiology, nuclear medicine, and pediatric radiology. His research areas include quantitative abdominal imaging, pancreatitis, nuclear medicine, and related therapies based on quantitative, non-invasive imaging markers, which will definitely have a huge impact on patient management and care by reducing the need for invasive testing. Without further ado, I am delighted to welcome Dr. TROUT to this virtual stage for this exciting topic on common pitfalls in manuscript writing. Then he will share interesting cases with us. Thank you.
Perfect. Thank you very much. Thank you for the invitation to speak. I'm only sorry that I didn't get to travel to Turkey to visit in person. Someday I will make it there. I really do want to visit at some point. So thank you for the stage. So I'm going to start with a talk on common pitfalls in manuscript writing. This grew out of a presentation I gave at Society of Pediatric Radiology a year or so ago. And then once we get done with this, we'll pause briefly if anybody has any questions or point of discussion, and then we can go on to some of the pediatric cases that I'll be showing. So a couple of disclosures. I recently stepped down from being an assistant editor for Pediatric Radiology, our society's journal. I'm no longer doing that. I do still review for the journal, and I am an associate editor for Radiographics, where I lead the nuclear medicine section of that journal. So a lot of what I'm going to talk about today builds out of my experience as an editor, and then also out of my experience as an author, as a reviewer, and the work that I do with our trainees here in Cincinnati to help them get ready for work or for publishing their research. So I'm really going to talk about 13 different things sort of over the course of this talk. These are what when I put this talk together, decided were sort of the 13 most common pitfalls that I was encountering and I was seeing people engage in, and so wanted to have a chance to talk about. So we're going to kind of move through these in order here, and I'll expand a little bit on each one of them. I do want to call people's attention to several good journal articles about writing manuscripts. The three on the left-hand side here, these are journal articles. They're published in AJR or in this actually is not a radiology journal, but another journal that talks about writing articles. And this is actually a book chapter. If you don't have access to these articles, please email me, and I'm happy to send them to you if you want them as resources as you think about writing your own papers or working with trainees on papers. So let's jump right in to the 13 pitfalls. The first pitfall that I talk with people about is failing to establish authorship up front. This is one of the things that I've found through experience that can create the biggest difficulties between collaborators and can result in the most hurt feelings, with people feeling like they were left out of some publication they should be included on. Now, the answer is not just simply to include everybody on every single article. There are specific criteria that an author needs to meet, but these criteria are relatively easy to meet. And providing folks an opportunity to join an article can be a good way to build bridges and build collaborations. But it's important to set the understanding up front in terms of who's going to be an author and what the author order is going to be, so that when a paper eventually comes out, somebody's not upset because they thought they were going to be first author and then there's second author or middle author or otherwise. And getting this set up front and solidified can avoid a lot of hurt feelings. Next pitfalls I want to talk about are sort of big picture pitfalls as it relates to manuscripts. The two things that I see here is manuscripts that try to solve the whole world's problems or try to do far too much. What I tell trainees is they have to remember that each manuscript really only answers a very small portion of a question. And so trying to turn a manuscript into the entire encyclopedia on some topic or making claims that the manuscript solves all the problems in one area really is too grandiose, and it undercuts the actual purpose of the manuscript. So we all need to recognize that our manuscripts really only answer a small piece of the question or a piece of the puzzle, and really can stay focused on that small piece. When you try to get too big, it just becomes confusing, it becomes grandiose, and it can undercut the strength of your argument. When I talk to trainees about constructing a manuscript, I sort of give them the visual of an hourglass. And really the way that I frame this to them is that the manuscript sort of has an hourglass shape in its flow. The introduction, or the first part of the manuscript, is quite broad. It sets the stage for the question that's going to be answered by the manuscript. But it very quickly narrows down at the level of the purpose statement, or the end of the introduction, to what very small piece of this question are you going to answer with your manuscript. And then the entire manuscript is at this very narrow part of the hourglass, right? It's very focused, and it's answering a very specific question. Again, it's not trying to do everything, but the bulk of the manuscript, purpose, material and methods, results, and then the first paragraph of the discussion, which summarizes the results, is at this narrow part here, very focused on the very specific question that's being asked with the manuscript in question. And then you broaden back out with the discussion. So the introduction sets the stage as to what very focused question you're going to answer with your manuscript. You answer that, then you come back out to the discussion, talking about how that focused question contributes to the bigger picture. But again, not trying to do more than exactly what you did in your manuscript. You don't need to try to make your manuscript seem like it's more than it is. A well-done manuscript can stand on its own without trying to do too much. The second big picture thing that I talk to people out that can really sort of derail a manuscript is inconsistent or changing terminology. And so what I tell people is, if you're going to refer to an examination with a specific phrase, use that same exact phrase throughout the entire examination. So if you are going to say, if you're doing, say, pancreatic imaging, which is what I do all the time, if you're going to say pancreatic MRI, say pancreatic MRI throughout the whole exam. Don't say pancreatic MRI and then say MRCP and then just call it MRI. And you want to make it as easy as possible for the reader to follow what you're doing. And you can do that by being consistent and routine and very sort of regimented in your terminology, and not changing it throughout the course of your exam or throughout the course of your manuscript. So now getting more specific in terms of individual sections of the manuscript, the biggest pitfall I see in the abstract is when the abstract summarizes too much. Abstracts can be very difficult to write because they're short, 250 to 350 words. You do not have a lot of space, but what I see people doing is going too far over to the side of summarizing to fit it into the abstract. In other words, they just make statements of results instead of actually presenting results. And so while you do need to summarize, you need to present specific results in the context of your abstract. So statements should be supported by numerators and denominators, or actual p-values, actual group measurements, so that the individuals that are reading the abstract, recognizing that most people don't actually read the whole paper, they just read the abstract, they can understand the entire study and can see the actual results, rather than statements of examination A was better than examination B. How much better, right? What was the p-value? What was the actual difference between the two? So provide that specific data. Don't summarize too much. But do recognize that you can't cover everything in your abstract because it is so short. So you need to focus on what's important, what are the key takeaways from the manuscript, and then give specific details about those key takeaways. Then for the introduction section, key pitfall here, or common pitfall here I see, is that the purpose statements in the abstract and the introduction don't match, right? So those purpose statements should be the same. In your abstract, you're going to have a purpose statement or an objective statement, and that should match the purpose statement in your introduction. Ideally word for word, but if you can't do word for word because of word count limitations in the abstract, make it as close as possible. Where I see people going wrong is they will have a purpose statement in the abstract that seems to suggest they're going to be doing one thing, and then the purpose statement in the introduction is different and suggests they're going to be doing something different. So those two should match. In the methods section, assuming the reader will understand as well as you do. And what I mean by that is that by the time we are writing up our manuscripts, we understand our research in incredible depth. We know exactly what we did, we know exactly what we found, but what we need to do as authors is help the reader understand exactly what we did. We can't assume they will understand what we understand, and so we need to be very declarative and very descriptive, telling our readers exactly what we did and everything we did. So every step we took in the methodologic process, exactly what techniques we used to do our measurements or to do our analysis, and being very specific such that there's no guessing about why we did what we did or guessing what we did, and no guessing about how we got to a result that we got to. So being very explicit and very deliberate in laying out everything and exactly what you did in your methods section. Then in the results, what I tell my trainees is that the methods and the results should inform one another. There should be no result that did not have a method that explained how we would get to that result. And there should be no method that does not have a result. And so sometimes when you're writing a manuscript, it can be helpful to break both sections down, the method section and the results section, into matched subheadings. So it's either easy for the reader to follow exactly what you're doing. Here was this method or this technique that we did, and then here was the result we got from that. Here was this method, here was this result. And so every result should have a supporting method. Results also should be supported by the actual data. So again, sort of like I was talking about in the abstract, providing just a p-value for two groups that you compared is not enough. We need to see the actual measurements for those two groups. And when you are quoting percentages, you need to give the numerator and denominator so people know the sample size that went into calculating that percentage. And no statistical result or no results in general should be presented without a confidence interval. Because as we all know, research reflects a sample of the total population. And so there is always going to be some uncertainty in the results that we get out of our sample. And so we need to faithfully document that uncertainty through use of confidence intervals that help us understand exactly how likely it is that the true result is with the result that we found in the study. Other pitfalls here, interpreting the results. So the results section, I tell trainees, the results section should be statements of fact. That is not a place to interpret your results or to try to put your results into context. Interpretation and context come in the discussion section. And so the results should be a pure statement of fact, no interpretation. And then the last pitfall in the results section is when authors duplicate between texts and tables, right? Texts and tables should be distinct from one another. Tables can contain a lot of data, but then you don't need to repeat that data in the form of the text. You can simply refer to the table, and it can be a very powerful way to convey data. But duplicating a lot of material between text and tables is a waste of space, and it just makes your manuscript more difficult to read. Other key bullet points here, there should be, again, nothing in the results section that wasn't described in the methods section. All your data should be here, but no interpretation of your data. And then the tables really should build on the text, and the text should highlight the key findings in the tables. They should not duplicate one another. So 4 key pitfalls in the discussion section, and that sort of brings us to the end of this piece of things. Over-concluding. So in other words, making broader conclusions than what you can make from your manuscript or from your research project. Like I mentioned before, you cannot solve every single problem with one manuscript. You are really addressing only one small piece of the puzzle. And so your conclusions should be focused on that small piece of the puzzle. You shouldn't be making broad, expansive conclusions based on the findings of your very focused research. And importantly, when you are concluding, your conclusions should be supported by the evidence that is in your manuscript, right? You shouldn't be extrapolating or extending your conclusion beyond what your data can specifically speak to, right? If you start doing that, the reviewers and the readers are going to think you become overly grandiose, and they're not going to necessarily believe what you're concluding. And so The data should be there to support your conclusion, and your conclusion should be limited to the data that is contained within your manuscript. The second pitfall here, trying to hide your faults. And what I mean by that is missing or failing to acknowledge the limitations of your work. No research is perfect. I'm going to talk about this again in a minute here. Every research study has limitations. And so we really ought to be acknowledging those limitations. Your readers are going to pick up on those limitations. The reviewers are going to pick up on those limitations. So it does you no service to try and hide those limitations or to pretend they don't exist. I tell my trainees, be declarative about the limitations. In the limitations of the manuscript, in the limitations section of the discussion, state the limitations of your work, be clear about it, and be honest about it. Because if you don't call it out, the reviewers are going to call it out, and they're going to use that as a reason to reject your paper. What follows immediately on that, this is a bit of a matter of opinion, this point number 12. I call this making excuses. Some people, when they describe a limitation to their manuscript, they immediately follow it with a statement trying to say why it's not really a limitation. For example, the sample size in this study was small, which is causing large confidence intervals. Then the next sentence, but it's the largest sample that's ever been reported of this entity in the literature, right? I personally don't think that that is helpful. I think, to me, that sounds like making excuses. I think it is better just to simply acknowledge the limitations and let the readers put those in the context of the bigger picture. And then finally, overly long discussions are a big pitfall. And I'm finding this more and more recently, at least, is that discussions are becoming so long, right? A good discussion should be succinct and should be somewhere around 5 paragraphs. The first paragraph describing the finding of the current study, the second and third maybe paragraphs putting those findings in context of the broader literature, the fourth paragraph, your limitations paragraph, and the fifth paragraph, your conclusion. I'm seeing discussions coming through that are 12 paragraphs, 13 paragraphs. They're just too far ranging, right? They've expanded the bottom of that hourglass too far, and they're trying to be too broad with what they're discussing. And I think that just serves to distract. It serves to confuse unnecessarily because you're not focused on the actual research that is at hand in that moment. And so I encourage people to be succinct and short with their discussions and focused on the actual research that's in the context of the work that you are presenting. And to that end, the discussion is not a place to restate or reiterate all the data that you already presented in the results. You have to assume that the reader has read the results, and then you can use the discussion section to summarize that and put it into context. You don't need to be saying, we found this, 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 and this, which you already said in your results section. And then last, don't introduce new data in the discussion. The data should all be presented in the results section, and the discussion should reflect on that. You shouldn't be pulling in new data and saying, oh, and in an additional analysis, we found this, or in a sub-analysis, we found that. That should be presented in the results, and then your discussion should reflect back on that. So in summary, these are the 13 pitfalls that I talked about here. Again, there are other things, and this is certainly not a guide necessarily to writing the perfect manuscript, but these are some key things that it's important to try to avoid as you are writing manuscripts for publication in the literature. Now, I do want to touch on just a couple of other things before I end here. There are some important resources that are out there. Any of you that have written manuscripts before should be aware of these reporting checklists, the STARD checklist, the Standards for Reporting Diagnostic Accuracy, the STROBE checklist for observational studies, and then there are specific checklists for AI or machine learning studies, randomized controlled trials, meta-analyses, et cetera, right? Many of the larger journals have these reporting checklists on their web pages available to authors for download. I have a couple of screen captures. So for example, this is the STARD checklist here on the left, and then these are screen captures of the STROBE checklist here on the right. So these can be helpful to authors to help them make sure that all important elements of a manuscript have appeared in what they have written. And so That's how I tend to use them. Some journals ask you to submit these with your manuscript. I don't fully understand why, because then authors just send in these lists with a bunch of check marks on them. But where they can be useful is to, as you are wrapping up your manuscript, say, you know, did we specifically state the study objectives and hypotheses in the introduction, right? In the methods section, did we specifically describe the eligibility criteria? Did we talk about how we would handle an indeterminate index test or a reference standard? And so it sort of calls out, again, key pitfalls or key pieces of information that authors ought to be paying attention to. And so it can be useful in that regard. So I would encourage you, as you are writing each of these different types of studies, to go find these checklists, and you can see the list of the names there, and use them potentially to guide your writing, or at least to make sure you've covered everything when you write up the manuscript. And then a couple of last tips here. Again, not pitfalls, now more tips. I recommend you try to find your friends. And what I mean by that is, I talked a little bit about how it's important that we help our readers understand exactly what we did, and that by the time we are writing a manuscript, we understand what we did in such incredible depth that it can be difficult for us to sort of back up and realize exactly what it will take to help somebody else understand what we did. And so it can be helpful to have people who are willing to review your manuscript, to provide you feedback, to make sure that it is clear to them as an outsider what you did in your work. And they may also identify flaws in logic or other things that you can address. And so having a group of individuals that you can bounce things off of can be very helpful to helping you produce the best product when you go ahead and submit. Now, should these individuals be given authorship? Again, that depends on whether they meet the other author criteria. And so I point you back to those author criteria that I laid out before. Somebody who reviews a manuscript for you, as long as they had input earlier on in the course of the project, even if they weren't involved in all steps of the project, can be counted as an author according to criteria. And so that can be a way to get people involved. And so many of us have sort of groups that we work with where we sort of share manuscripts, and we bounce manuscripts around off of one another to get input to make sure we're really conveying our findings when it comes time to publish. And then the last point where I see people get hung up is knowing when to stop. As I mentioned before, no research project is ever perfect, right? We have to acknowledge our limitations. Every project has limitations, so we need to acknowledge those. I have seen trainees and colleagues get so hung up on limitations or so hung up on trying to make a research work perfect that they never finish it. And so you have to be able to decide when it is good enough and when it is time to be done, so that you can move on to the next thing, so you can move on to getting that manuscript published, and you don't end up getting paralyzed or trapped in this cycle of trying to get that one manuscript perfect, and it never will be perfect. So that's just another piece of advice around that. So that's the end of my talk around manuscript writing and pitfalls. I do have some cases that I will show next, but I want to pause and give people an opportunity to raise any potential questions that people have, or to ask me to clarify anything that perhaps wasn't clear.
So I think you can just move on, and then if you have any questions at the end of the session, you will try to answer
Perfect.
them.
Okay, that's fine. Yeah,
Okay.
no problem. And people can email me questions as well, and we can do it that way. Okay. Oops. Sorry. Hang on one second. There we go. Okay. Can you see my next presentation now?
Yes.
Okay, perfect. So I'm going to go through a few pediatric cases here. I have focused, so as was said, my areas of expertise and focus are around abdominal imaging, and then also in nuclear medicine. Now, I'm not showing nuclear medicine cases today. I focused entirely on abdomen imaging cases, and I have a few cases here that I have screenshots for, and then I'm going to maybe pull one case up on our PACS system to show toward the end, because I need to be able to scroll through those images. So it looks like we have about half an hour here. I may not take that whole time, but we'll see sort of how this goes here. Okay, so this was a 9-year-old that presented with an abdominal mass. So we have on the left here a coronal single shot fast spin echo T2 weighted image, non-fat saturated. And then on the right, 2 axial slices from the same, also a T2 weighted single shot fast spin echo sequence. This patient was imaged with one of our pancreatic protocols. We have done some research in the past and through clinical experience have found that MRCP can be difficult to do in children. We see a high frequency with which the 3D heavily T2 weighted MRCP sequences, those true MRCP sequences, can become compromised by artifact due to respiratory motion. And so in our clinical protocols, we do perform those 3D MRCP sequences, but we also perform multiple other sequences that are designed to serve as backups to allow us to get reasonable image quality even when that 3D MRCP sequence fails. And so this is one of those backup sequences for us. And this is a non-fat saturated T2 weighted single shot fast spin echo sequence. We do somewhere between a 3 and a 4 millimeter slice thickness in both planes with no gap. Okay, and this is respiratory triggered. So you get good image quality on these images, and it can save you when that MRCP, that true MRCP sequence fails. And so what we see in this 9-year-old with an abdominal mass, we see a fluid-filled structure here in the right upper quadrant in the porta hepatis, and there appears to be additionally a dilated bile duct extending out into the left hepatic lobe. If we look at this upper slice, down here on the bottom here, we do see that there is dilatation of the intrahepatic bile duct, slightly more on the left side than on the right side. And here's an axial image right through that fluid-filled structure in the right upper quadrant. And what we see within that fluid-filled structure are multiple layering stones or debris. This is the gallbladder. Here, adjacent to this structure, you can see it's incompletely distended here, but this is the structure that was producing the mass that was felt by the provider. And so this is a choledochal cyst, and I'm going to discuss a little bit about the different types of choledochal cysts. But what we can see here is this is the dilated common bile duct and common hepatic duct, and then you have saccular dilatation of the intrahepatic duct. And so this turns out to be a type 4 choledochal cyst. And these patients are prone to developing stones within that choledochal cyst that can then go on to obstruct the biliary system, resulting in cholangitis, or can obstruct the pancreatic duct and result in pancreatitis. These have to be surgically resected because they predispose potentially to cholangiocarcinoma in adulthood. The reason that these are thought to predispose to cholangiocarcinoma is at least the type 1 and type 4 choledochal cysts, which I'll show you that classification here momentarily, are associated with a long common channel or an anomalous pancreatic biliary junction. And what that means is that instead of joining at the level of the ampulla, the pancreatic and bile ducts join above the level of the ampulla, and so they're outside of the sphincter, and you have a long common channel. And so you can get free reflux of pancreatic juice up into the biliary tree that causes cholangitis and can predispose to cancer, and you can also get bile reflux into the pancreas, causing pancreatitis. So that's why these have to be dealt with. So here is another patient with a choledochal cyst. So this one we're seeing on MRI here, and then on endoscopic retrograde cholangiopancreatography, or ERCP. And so again, in this case, we see a cystic structure containing multiple stones. In this case, the dilation appears to be essentially entirely extrahepatic. We're not seeing much intrahepatic dilatation, and maybe isolated to the common duct. And then this is partial visualization of that long common channel. ERCP here shows the long common channel here. So you have the pancreatic duct coming down here. It's mildly irregular, but it joins the common bile duct here, and the ampulla is down here near where the wire comes out of the scope. And so there's a very long common channel here that is associated with this choledochal cyst and dilatation of the common bile duct. So what is a a abnormal pancreatic biliary junction. There is not an abnormal threshold value that has been established for pediatrics. So in adults, the cutoffs started at about 1.5 centimeters. Depending on some papers, they've come down as short as 6 millimeters in terms of what's abnormal. Normal has not been defined for pediatrics, but what I tell trainees is if you see a common channel, it's abnormal. Because in the normal situation, the pancreatic and bile ducts should join at the level of the ampulla or should not be visible, right? They should be coming together at the expected location of the ampulla, right in the wall of the bowel. But in cases like this, we can see the pancreatic duct coming down here, the common bile duct coming down here, and this long common channel here, and then the associated extra and intrahepatic biliary ductal dilatation, again confirmed here with an ERCP, demonstrating that long common channel, the dilated biliary tree, and the dilated pancreatic duct. So again, if you have a dilated duct that you are suspecting to be a colodocal cyst, you should be looking for that long common channel. And if you see any length of common channel in a child, you should consider it abnormal. Here's an example of a patient with a long common channel that developed pancreatitis. So like I said before, they're predisposed to stones within the colodocal cyst. They're also predisposed to pancreatitis. So we can see on an axial non-fat saturated single-shot Fessman echo T2 weighted image here, we see the pancreas is swollen, the duct is dilated, and there's pancreatic edema. Here on a fat saturated T2 weighted image, pancreas is edematous, there's a small amount of peripancreatic fluid. And then here is a maximum intensity projection image of the MRCP demonstrating the long common channel here. Here's the pancreatic duct coming in, joining the common bile duct. And we have this long common channel with intrahepatic biliary ductal dilatation. And in many cases, we've seen large stones forming in that common channel. In fact, we've had several cases come through where the stone completely fills that long common channel, preventing you from seeing it. And so in a patient with a dilated biliary tree where you're concerned about the presence of a colodocal cyst, you have to study very carefully both for the presence of long common channel, but also make sure that there's not a stone sitting there occluding that entire channel and making it not visible. So colodocal cysts, I think everybody is probably familiar with the Todani classification. That classifies colodocal cysts into 5 different types. Technically, Caroli disease, a so-called type 5 colodocal cyst, should not be included in this same system because it has a different embryologic origin. That's actually a ductal plate malformation as opposed to a foregut abnormality. So it's actually incorrect to include Caroli disease here. But we have type 1, type 4, type 2, and type 3 colodocal cysts. Type 1 and type 4 are the most common. So these are the ones that I showed you with the long common channel, where you have either isolated dilatation of the extrahepatic biliary tree or dilatation of both the extra and intrahepatic biliary tree. Type 1 is supposed to be just extrahepatic. Type 4 is supposed to be both extra and intrahepatic, and those are the ones that are associated with the long common channel. In practice, it can be difficult to distinguish a type 1 from a type 4 because some type 1s will have secondary congestion or impaired drainage of the biliary tree such that you get dilation of the intrahepatic ducts. And then when they resect this colodocal cyst, those ducts decompress. And so I personally tell trainees not to try to distinguish the two, just simply to describe where there is dilatation. That said, when you have cases like the first case I showed, where there was more saccular intrahepatic dilatation, that's a little more clearly a type 4 colodocal cyst. The ones where it's confusing is when there's more just sort of contiguous dilatation of the ducts into the biliary tree. I have not, well, I've seen 1, maybe 2 type 2 colodocal cysts, and I'll show you some images from the literature. But here's another example of a case where a stone, you can see it here on as a low signal structure on this balanced image, completely occludes that long common channel. So you have a dilated extrahepatic biliary tree, saccular dilatation of the left duct. So you believe there's a colodocal cyst here, but you see a junction of the pancreatic and bile ducts. You don't see a common channel here. Now, keys that this is abnormal are the fact that this junction is a long way from where that expected location of the ampulla is. So that should be one clue to you, because the two should join right there next to the biliary tree. But then you can also see the stone completely occluding that common channel here on the coronal image. So you need to look for that. Here's another type 1 colloidal cyst, again, presented with a large palpable mass, a very dilated extrahepatic biliary tree. There is some intrahepatic dilatation, but that resolved completely after they resected the extrahepatic portion. So like I said, it can be difficult to distinguish type 1 and type 4 colloidal cysts. Here's a type 4. This is that same case I showed before with the long common channel, the dilated extrahepatic ducts, and the saccular dilatation of the intrahepatic ducts. Type 2, I have only seen one ever in real-world clinical practice. These are a couple that have been published in the literature. Here you have a small saccular outpouching. These are described as a diverticulum-like outpouching from the extrahepatic biliary tree, the type 2 colloidal cyst. This one's very small. This one's very large. I would argue, though, there's something else going on in this patient, because in this case, the pancreatic duct is severely abnormal. So there's clearly chronic pancreatitis here. And you have dilatation of the entire biliary tree, as well as this saccular outpouching. So this may be something different, perhaps a contained leak from the biliary tree or something else, but it was published as a supposed type 2 colloidal cyst. And like I said, I've only seen one of these ever that I believe to be real. And then this is a type 3 colloidal cyst. So you have saccular dilatation, the so-called colloidal seal, saccular dilatation of the distal common bile duct at the level of the ampulla. And this can be a small saccular dilatation that's completely contained within the wall of the duodenum, or it can protrude out into the duodenum and cause some degree of obstruction of the duodenum. So that's the end of that case. This is the second case that I wanted to show you. This is a 15-month-old with Alagille syndrome. So Alagille, paucity of intrahepatic bile ducts. It's on the differential diagnosis for neonatal cholestasis, as you all know, which includes neonatal hepatitis, biliary atresia, and then Alagille syndrome. So this patient had known Alagille's syndrome, so no Kasai performed, but presented with this MRI. And we have a axial T2 weighted image here on the left, a T1 gradient recalled echo image without contrast here in the middle, and then a post-contrast image, also T1 weighted here on the right. And what we see is we see a large mass, T2 weighted hypo-intense compared to background liver, T1 weighted hyper-intense compared to background liver, and hypo-enhancing compared to background liver. And so concern was raised about this being something bad, some form of a tumor or otherwise, but this is actually a common manifestation of Alagille syndrome, the so-called macro-regenerative nodule. And so this was first described out of sick kids, and then we have since published a paper showing that this occurs not only in Alagille syndrome, but occurs in other situations where you have biliary abnormalities. And my hypothesis is that what this reflects is that the smaller caliber ducts in the far periphery of the liver are more affected by the disease than the larger caliber central ducts. And so when the liver regenerates, it regenerates centrally and gives this mass-like look to things. Characteristically, this mass-like or macronodular regeneration is right at the porta hepatis. Often when there are smaller foci, the area of macro regeneration sits right in the portal bifurcation. This can become confusing because we are used to comparing lesions to the background liver. And in this case, the background liver is so abnormal that it's giving us a false perspective. So in this case, this is actually normal T2 weighted signal intensity for the liver. The background liver is actually T2 weighted hyperintense, making this lesion appear dark. And same on the T1 weighted image. This is actually normal T1 weighted signal intensity liver. The background liver is just a little bit low in signal. And then on the post-contrast image, this lesion is not hypo-enhancing. In fact, what's going on is that the background liver is retaining contrast longer and giving the appearance that this is hypo-enhancing. So you have to be aware of this entity so you don't falsely state the patient to have a mass or a tumor. So Alagille syndrome, as I mentioned, eventually these patients can get some degree of fibrosis and they have these characteristic macroregenerative nodules. So here's another patient with the same. It was described to occur in 30% of cases by the sick kid group. But you can see this is less mass-like than that last case. It almost just looks like a geographic area, though rounded, of signal abnormality, T2 dark, iso-intense on in-phase imaging, but in this case, there happened to be preferential steatosis within that macroregenerative lesion, which we have seen as well. And then if you do imaging, in this case with MR elastography to measure liver stiffness, as you might in a patient where you're concerned about liver fibrosis, these lesions will appear softer than the background liver. And so occasionally, if you, for example, were to do an ultrasound, and you were to place your sampling for elastography within the area of macronodular regeneration, you might get a normal value for liver stiffness when in reality the background liver here is quite fibrotic. So you have to be aware of this entity when you're making elastographic measurements. Here's another example of a patient with Alagille syndrome and a macroregenerative nodule. So we see morphologic changes of fibrosis here on the T2 weighted fat saturated image, this reticular T2 weighted signal, and this lesion right at the bifurcation of the portal vein appears T2 weighted hypointense, but that's actually the normal liver signal. The background liver is abnormal. Again, appears somewhat T1 weighted hyperintense, but that's because the background liver is abnormal. And then through dynamic post-contrast enhancement, it can almost appear hypo-enhancing, but the reality is this is normal liver tissue in a background of abnormal liver. Now, we want to be careful just saying in all Alagille syndrome, oh, this is macroregenerative nodule, we don't have to worry about it, because patients with Alagille can get hepatocellular carcinoma. So we do need to be looking for imaging features that suggest that, but we also need to be aware that this is a far more common process than hepatocellular carcinoma. Like I said, this can occur in other entities. So here's a patient with biliary atresia that has a bit more of a lobulated macroregenerative appearance to things. Here's another biliary atresia patient with much more of a typical central macronodular regeneration that looks very much like those Alagille patients. And so you can see it in almost any biliopathy. So we see it in Alagille syndrome, we see it in biliary atresia, we see it in hepatic Langerhans cell histiocytosis, where the bile ducts are impacted and you get this central regeneration and the mass-like or macronodular regeneration. Now, again, in biliary atresia, we have to be careful not calling all of these things just macronodular regeneration because they can get hepatocellular carcinoma. And this was a low-grade hepatocellular carcinoma in a patient with biliary atresia with some sort of lobulated central regeneration. So we do have to be careful and have to still look for these malignant tumors, but be aware of this macronodular regenerative process that can occur in these patients. So that was the second case I wanted to show you. So here's the third case. So this is a 6-year-old with abdominal pain. So we have multiple images from a CT with both IV and oral contrast here. We see a cystic structure here that appears to be within the duodenum. We see a thin crescent of contrast material around this cystic structure, and that contrast material gets by and goes into small bowel. So you have a cystic lesion in the second portion of the duodenum, right near the head of the pancreas here, almost a claw sign here. So differential diagnosis here, is this a type 3 choledochal cyst? Is this an enteric duplication cyst? Theoretically, in a patient with a history of pancreatitis, you could have a pancreatitis-associated fluid collection in the pancreatic duodenal groove. I haven't seen those bulge into the bowel this much. So really the two top things for me are enteric duplication cyst versus type 3 choledochal cyst, or that choledochal seal. So you could do an ultrasound and look for the trilaminar appearance of the wall of this structure within the bowel. But in this case, that was just an enteric duplication cyst. I did want to show a couple of examples of type 3 colodocal cysts, including one that looked very much like this lesion we just showed. So here was the prior type 3 colodocal cyst I showed you, a small lesion. Here's a much larger lesion looking very much like this enteric duplication cyst that I just showed you. But in this case, it's a type 3 colodocal seal or colodocal cyst, type 3 colodocal cyst, type 3 colodocal seal. You can see it's at the end of the junction of the common bile duct and pancreatic ducts. And so in this case, they injected it. This was an intraoperative cholangiogram, but we confirmed the diagnosis with hepatobiliary contrast. So these are images from an MRI where we gave the patient Eovist, which is what we use here. And on delayed phase imaging, 20 minutes after administration, you can see contrast pooling within that cystic structure. So demonstrating contiguity with the biliary tree, as opposed to, had we done that in this case, contrast would not have filled this structure because this is not contiguous with the biliary tree. It is an enteric duplication cyst. But here is a type 3 colodocal seal. And when they injected the gallbladder in the operating room, pushed contrast down antegrade, they filled this type 3 colodocal cyst. This is another case I want to show. This is a 15-year-old girl presenting with abdominal pain. So I'm sure you've seen the theme now. Like I said, I'm an abdominal imager, so lots of liver, pancreas-related stuff. So this girl presented with abdominal pain. She has a large mass here in the left upper quadrant of the abdomen associated with the tail of the pancreas. We can see a pancreas claw sign around this mass, beautifully demonstrated on the coronal image here. So this is a large pancreatic tumor in a teenage girl. So the number one differential diagnosis here is a solid pseudopapillary epithelial neoplasm, the SPEN tumor in a teenage girl. Things that should be in the differential diagnosis: smaller masses in the tail of the pancreas, an intrapancreatic accessory spleen is possible. Other pancreatic tumors like adenocarcinoma or pancreatoblastoma, different age groups generally. We have seen one teenager with adenocarcinoma, and often much more aggressive appearing than this, and certainly much, much more rare than these solid pseudopapillary epithelial neoplasm, these SPENs that these teenage girls get. These lesions can have variable appearance. They're generally solid, but they can have cystic components to them. And so MRI may make them look like pancreatitis-associated fluid collections or otherwise, but this is pretty clearly a pancreatic mass. Now, why am I showing the case of a relatively common, relatively understood entity? This case is somewhat unique in that this patient's tumor ruptured. So this was the initial presenting CT scan in this patient. They came back 3 days later with increased abdominal pain and had ruptured their tumor. So large tumors like large SPEN tumors can rupture, can hemorrhage. They can both hemorrhage within the tumor and hemorrhage to the point that they rupture, and it can be catastrophic in some situations. So uncommon occurrence here, but a nice example of a ruptured solid pseudopapillary epithelial neoplasm in a teenage girl. This is a 9-year-old, another case here, a different case that presented with abdominal pain. So this is a entity that I want to talk about. So we have on the left here, axial images from fat-saturated T2 weighted images, 2 images here, one more at the level of the body and tail, one more at the level of the head and the unsnit process. And then we have a T1 weighted fat-saturated post-contrast image here in the upper right, and then a diffusion weighted image, a B-value of 800 down in the lower right. And so what we see is this patient has pancreatitis. The pancreatic duct is dilated. There's acute peripancreatic fluid and pancreatic parenchymal edema. If you follow the duct down, it comes down to the head of the pancreas where there's this mass-like area of signal abnormality that is surrounding the duct. That mass-like area demonstrates restricted diffusion and is sort of heterogeneously enhancing on these images here. So differential diagnosis, of a pancreatic mass in a 9-year-old. So we do need to be thinking about things like pancreatoblastoma. Generally, those are larger, more aggressive appearing than this particular lesion appears to be. Adenocarcinoma in adults certainly can cause duct obstruction. It gives you that so-called double duct sign where you're getting obstruction of both the pancreatic and the bile ducts. Adenocarcinoma, exceedingly rare in children. Solid pseudopapillary epithelial neoplasm, or the so-called SPEN tumors, can also occur. This patient's a little bit young, and in my experience, they generally don't obstruct the duct except when they get very large. And so this actually is a case of autoimmune pancreatitis. So one other entity we need to be aware of when seeing masses in the pancreas. The other entities, of course, are metastases and things like that. But this is mass-like autoimmune pancreatitis. Autoimmune pancreatitis is known to obstruct the pancreatic duct, dilate the pancreatic duct, can also dilate the bile duct, and can give restricted diffusion like this. So a characteristic location, a characteristic look to things, treat with steroids. If the lesion begins to improve and resolve, it's a diagnosis of exclusion. They can biopsy. IgG4 levels, which are commonly elevated in adults with autoimmune pancreatitis, are rarely elevated in children, but they can biopsy and see inflammatory cells. I want to show a couple of other examples of autoimmune pancreatitis. So that's a beautiful example of solitary mass-like autoimmune pancreatitis, the classic look in the head of the pancreas. Here are two other patients with autoimmune pancreatitis. On the top here, the classic so-called sausage pancreas, right, where the entire pancreas is swollen. We see a small amount of peripancreatic edema on this T2 weighted image. Heterogeneously T1 hypointense, sort of heterogeneous enhancement. And in this case, we have a nice example of that double duct dilation. So when you see bile duct dilation in the context of pancreatitis, once you've excluded the presence of a stone, you really ought to be thinking about autoimmune pancreatitis. Now, simple interstitial edematous pancreatitis can cause the pancreas to get big and swollen like this. When I start to think about autoimmune pancreatitis as opposed to routine interstitial edematous pancreatitis is when the abnormalities of the pancreas seem to be out of proportion to the peripancreatic abnormalities. And what I mean by that is this pancreas is very swollen, right? But we're not seeing a lot of peripancreatic edema. There is peripancreatic edema here, but it's it's sort of a thin little rim around the pancreas. There's not a lot of peripancreatic fluid. And so the pancreatic abnormalities are out of proportion. You have the bile duct here. This is where I'd be thinking autoimmune pancreatitis. I already showed you the solitary mass-like autoimmune pancreatitis. This is another form of autoimmune pancreatitis that we have seen where there are multiple masses in the pancreas. And so instead of uniform swelling of the pancreas, there are multiple areas, mass-like or rounded areas of abnormal T2 weighted signal scattered throughout the pancreas, T2 weighted hypointense compared to the normal pancreatic parenchyma. So when I see multifocal masses in a patient without any reason to believe that they have metastases, autoimmune pancreatitis is going to be on my differential in that case. So again, when do I think about autoimmune pancreatitis? Certainly in patients who have other autoimmune diseases, like inflammatory bowel disease. In patients, like I said, with a very abnormal parenchyma, but without a whole lot of peripancreatic edema or fluid. When you see that classic sausage pancreas, that can point you in that direction. In adults, they describe this halo. They often describe it actually being T2 weighted hypointense with delayed enhancement. I've not seen the T2 hypointense halo in children, but we have seen the enhancing halo. You almost get a little bit of a sense that in this particular patient. And then whenever I see mass-like or focal pancreatitis. So these are the situations where I think about autoimmune pancreatitis as opposed to other forms of pancreatitis in a child. All right, so now I'm going to stop sharing for a moment here because I want to pull up one last case that was requested by one of my colleagues, Dr. Darren Kuyu. I'm going to pull up the case here and then share my screen. But I just want to remove the protected information. So let me just get this pulled up. Oops. Jeez. Okay. It's pulled up, and then one more. This, okay. Coming back. Bring this back up. Back to Zoom. Share. And going to, sorry, one thing, I just want to share a portion of my screen. Drag this around. Okay, so what you should see on the left is one CT scan, and on the right, a different CT scan from the same patient. So we deal with a lot of pancreatitis here at Cincinnati Children's. I've shown you a few cases of pancreatitis already. So this was the initial CT in this patient. And what you can see is that there are findings here of chronic pancreatitis. So there's relative preservation of the head and uncinate process of the pancreas. But as we get out into the body and tail, there's volume loss or thinning of the pancreas. We can see the duct is dilated. There's excessive lobulation. So these are all findings of chronic pancreatitis. No calcifications in this case, which would be the other CT finding. And the other thing we can see is that the splenic vein is occluded, and there's a lot of varices here, both gastric and peripancreatic varices. So this patient has chronic pancreatitis. So here at Cincinnati Children's, one of the treatments that we offer for our patients is what's called a total pancreatectomy with islet cell autotransplant. And so I'm going to show you back to a PowerPoint slide here and enlarge the sharing region here. So this is a TPIAT, and then I'll show you the post-operative CT images. So basically what they do in this case, this is offered to patients who have chronic pancreatitis that is a source of recurrent episodes of superimposed acute pancreatitis, or they have chronic pain. And the idea is take the entire pancreas out to remove the source of recurrent inflammation and chronic pain and restore those children to a more normal life. Now, the issue, as we all know, is the pancreas produces both digestive enzymes and it produces insulin. And so if you simply take out the pancreas, you can supplement the digestive enzymes easily, but you will turn that patient into an unstable diabetic, or the brittle diabetic, as we call them in the US. And so what they do for these patients is they take out the pancreas, they isolate the islets of Langerhans, which are the ones that produce the insulin, and they embolize those islets into the portal vein and back into the liver. And those islets get stuck in the vascular system of the liver, and they can actually establish themselves there and produce enough insulin to stabilize that patient so they are no longer an unstable diabetic. And so what they do is they do the pancreatectomy, they do a post-pyloric Whipple, or more than a Whipple actually, post-pyloric pancreatectomy. They do a resection across the duodenum. They remove the common bile duct and the gallbladder. They remove the entire duodenal C-loop. They do a duodenal jejunal anastomosis to recreate continuity with the stomach. And then they bring up a limb to drain the biliary tree here. And so basically you end up with the stomach draining down through this jejunal limb, and then a roux limb bringing bile back down, and you have entirely removed the pancreas. They usually remove the spleen as well, though they are experimenting with spleen-preserving total pancreatectomies. So these patients the post-operative imaging, these patients can look a little bit odd, but now that you've seen sort of the anatomy as it should be, Now this is shortly after the procedure. So we see the patient's stomach up here in the left upper quadrant. They put a gastrojejunostomy tube in during the procedure to sort of tack things down or maintain the position of things and to keep the anastomoses open. So you can see the retention balloon here in the stomach. It comes out through the pylorus, down through the duodenum and into that jejunal loop, extending, all the way down into the pelvis past the distal anastomosis where the roux limb is connected into. And so the roux limb, you can see coming up here, posterior to that limb, draining the biliary system and then anastomosing back down there. So they end up back in contiguity. You can see the portal venous system here. Spleen is gone. Pancreas is entirely gone because the pancreas has been embolized. Important things, postoperative complications in these patients, because they're putting material into the portal vein, these patients are predisposed to portal vein thrombosis. And this patient actually had some degree of thrombosis on an earlier scan than this. They also, it is possible if the jejunal limb becomes freed up for whatever reason that you can get internal hernias behind that jejunal limb. But this is the typical or expected look for a patient that has undergone a total pancreatectomy with islet autotransplant with reconstruction here. The other thing that we will see in these patients is, again, the islets are embolized into the liver. And so their liver can actually develop some degree of steatosis in response to the presence of those islet cells. I'm going to close this, and then that actually reflects the end of my talk, and we're toward the end of the hour here. So thanks everybody for your attention. Please do contact me with questions if you have any. And there may be one in the chat here. Do you use the Comey classification for pancreatic biliary maljunction or any other classification system to help the surgeon? So no, we don't use that. We simply report the presence of an abnormal junction. We will describe the length of that abnormal junction. And then the other thing that the surgeons often want to know is how far the bile duct goes down into the pancreas, because they want to resect as far down the bile duct as they can go. So the distance between the junction and the top of the pancreas is another important measure.
So, Dr. TROUT, thank you very much for your very useful presentation regarding manuscript writing, and also thank you very much for sharing us teaching cases. I hope to see you in our country in the near future. Thank you very much. For
I look
your
forward
time.
to it.
Yeah, thank you.
Thank
Bye-bye.
you.
Bye. Thank you. Evet. Oturum sonuna geldik. Çok teşekkürler katılımınız için. Herkese iyi akşamlar diliyoruz.